Now, when we were discussing our patient Anita, which was 51-year-old female, although she did not have any past medical history, but usually with a patient who develop osteoarthritis early on, they usually have associated developmental dysplasia of hip. And the patient with development dysplasia at hip in when they were a child, this can actually lead to accelerated degeneration of the hip joint, leading to adult dysplasia of the hip joint. And they may present as early as in their early 20s as well if they are left untreated. For example, if the hip joint was left untreated, this may eventually lead to having a problem such as, for example, at the age of 20 or 22, they may have a very marked degeneration of the hip joint. Therefore, whenever you are actually looking at the patient of the hip osteoarthritis, you have to rule out whether is it primary or is it secondary. And if it is secondary, could it be the problem due to adult dysplasia of the hip, or is it there is no associated structural abnormality? Probably the problem is degeneration of hip. Hip dysplasia, as you know, the problem could be at the level of the acetabulum. Usually the acetabulum can be shallow, hip may be subluxed or completely dislocated, or despite the treatment, for example, which was done early on, there may be some structural abnormality of the acetabulum which may lead to adult dysplasia of the osteoarthritis. Now we can classify. There's a different form of a classification called as Crowe classification. And this classification actually helps us to distinguish that how much problem is there at the hip dysplasia, how much dysplasia is there, and how much something which needs to be done as well. Now, the Crowe classification is actually, there are two forms of it. One is with the basically how much under coverage of the head is there, and other is related to the how much acetabular dysplasia is there. Now, combining these two, this actually leads to some form of a classification called as Crowe classification. Type 1 is in which actually the proximal subluxation is less than 50% of the height of the femoral head. And how do we calculate that height? What we calculate the total height first from the tip of the highest point of the L of the ilium till the lesser trough. We calculate that is, if it's bilateral, we calculate it on the both side. But if it's one side is normal and other is abnormal, we first calculate the length on the normal side. That is the actual length. And then we calculate from this actually the top of the head, highest point of the femoral head, how much the distance is to the lesser trough. This is the normal value. This should be subtracted, and then we calculate the abnormal side, that how much this head is actually subluxed posteriorly and laterally. This actually gives you a sort of a dislocation, how much. If it is less than 50%, it's Crowe zone 1. From 50 to 75%, it's actually subluxation and it's Crowe zone 2. Then becomes grade 3, in which there is 75 to 100%, and almost more than 100% means actually the femoral head has gone up above the level of the L of the ilium. That is, either it's markedly high, this can be groin zone 4 as well, or there is the abnormal side is grossly abnormal as compared to the normal side. Now, once we have classified this, there is another form of a classification other than the Crowe as well, and that is called the Orthopaedic classification. In this, they are basically mainly on the pathophysiology, whether it is a dysplastic hip, and we have a femoral head which is subluxed but still contained in the acetabulum. The acetabulum is dysplastic, but femoral head is not dislocated, it's just subluxed, still somewhere over there in the contained. Then there is low, and there is actually in which there is femoral head articulates with the false acetabulum that partially overlaps the true acetabulum. Now what happens is that once the head is dislocated, it's going to move upward. But as this is the normal acetabulum, it dislocates and goes up. It can dislocate somewhere in a false acetabulum which is partially in contact with the true acetabulum. That is, that it has not gone way above. Now it could also be high as well, or it could lead to a problem in which the false acetabulum and the true acetabulum are quite far apart. The head is actually gone up when femoral head articulates with the hollow in the acetabular wing. The problem is that there is a false acetabulum formation in the iliac wing, and the head is actually articulating at that level. Now, when we are dealing with the surgery, this is actually why these classification is important and why they have formed this, why they're actually worried about the femoral head going upward. The problem is that you cannot bring more than 5 centimeter down. If you increase the length of the limb by more than 5 centimeter or decrease it by 5 centimeter, that is actually where the problem starts. Because it's not that simple that you just bring the head down, put it in, screw it up, and that's it. Because when you're going to lengthen the limb, there's going to be stretch at the vessels, there's going to be stretch at the sciatic nerve, and this may eventually result in a neurovascular injury. So you have to keep that in mind, that you have to bring the femoral head down, but you don't have to increase the length of the femur. Therefore, sometimes you may have to go for some form of shortening or osteotomy at the proximal femur as well. So that is why when we are doing the total hip in these patients, we have to keep that in mind, because there is always some distorted anatomy, there is always some form of LLD as well. So you don't want to reduce or increase the length too much, leading to some form of injury as well. And if you reduce it more than 5 centimeters, actually the muscles bulk out, and this is actually muscle cannot act on that joint properly. Therefore, whenever we are actually going for some form of surgery, we have to keep that in mind, that what is the LLD. In our patient, there was actually no LLD, therefore that almost ruled out that there is nothing wrong with, there is no associated dysplasia of the hip joint. If you see it over here, this is classically bilateral DDH. This is the true acetabulum, and the head is gone up, and you can appreciate this forming a false acetabulum. This is kind of a low acetabulum in which the head has gone up. It's forming a false acetabulum, which is actually some sort of an oblong associated part of the true acetabulum as well. And when you're going to bring this down, you don't need to bring it a lot down. Therefore, the more higher this is, actually the more problematic it becomes. And that is why when the femoral head goes up more than 100% or more than 75% is given a higher grade in Curie classification as well, because it is actually more problematic to bring it down, and there are more associated complications with the surgery involving the adult dysplasia of the hip joint. Now, usually if you see this, there is marked degeneration, reduced joint space, sclerosis, subchondral cyst, the head is deformed, you probably require some form of surgical treatment. This cannot be corrected with just conservative treatment. And mostly whenever the patient comes with dysplasia of the hip, the problem is that we don't have options mostly except surgery. But the main thing we need to look at is that what is the age of the patient at which we are doing surgery, because that is going to determine what type of surgery can be done, whether you need to go for cemented or uncemented type of a total hip replacement. Now, if you see, this is another form of dysplasia. This actually, you see, acetabulum is shallow, more vertical, with the subluxed actually head of the femoral head as well. Probably for this side of a situation, you need to go for early total hip arthroplasty. If you see this is another bilateral involving degenerative joint. There is some form of a pistol grip deformity as well. I can see over here that the greater trochanteric is overriding, along with the head neck ratio is disturbed as well. Now, this can be due to the patient may having some form of impingement. Along with the dysplasia, the patient can have isolated dysplasia as well. Now, what is the operative treatment? Operative treatment mainly includes the total hip replacement. That is, if you see on this side, if the right side looks okay, although there is some form of a shallow acetabulum as well, there is some degree of dysplasia on this side as well. This is a very short neck on the right side, but on the left side you can appreciate that although neck is short, head is deformed, and it's going up into the false acetabulum, and there is actually, this is the true acetabulum which has become shallow and actually more of osteopenic, and this is the true false acetabulum in which the head is actually articulating in the hip joint. For that, probably you would require some form of surgery, and you need to bring it down like this. Now, this is the pre-operative templating of the same patient being done before the surgery is being planned. because whenever you're going to bring it down in form of a total hip joint, this is going to increase the length of this limb. Therefore, you need to pre-operatively template it, that if you apply this sort of head size, this neck size, what is the offset you're going to achieve and how much lengthening is going to be achieved at the limb. You need to make it sure that you do not lengthen the limb too much. Probably at 1 centimeter is acceptable, up to maximum 2 centimeter. But if you lengthen it more than 5 centimeter by correcting the actually anatomy, and that can eventually lead to sciatic and neurovascular injuries, which could be more problematic later on for the patient as compared to the this dysplasia. Therefore, whenever we are dealing with that, we have to pre-operatively template it. We have to look for how much LLD would be there and how much LLD we need to recreate, so that this the lesser troch in both levels are actually at the same level in the now post-operative X-rays. And sometimes if there is a lot of offset is being done and the limb actually increases, you may have to go for some form of a shortening osteotomy at the proximal femur, therefore to remove that limb length discrepancy as well. As you can see it over here. Now this was the false acetabulum. This was actually a sort of a large dead space which was there. Once they've created the head in the true acetabulum, this been filled up with bone graft and screwed well in place, so that actually they've pulled up the bone graft over there. If this would have been left alone, this head could have subluxed back into this and leading to failure of the prosthesis. Therefore, you need to put the head prosthesis in the true acetabulum, but you need to do something about the false acetabulum as well. And sometimes you have to fill it up with the graft, sometimes you have to fill it up with some form of a cup and put the graft in, or some form of bone substitutes. You can put a cup there, put some bone substitutes and fix them with screws. Something needs to be done depending upon what is probably the best choice. Mostly it's the surgeon preference what you need to do, but something needs to be done of the false acetabulum as well. Otherwise, this prosthesis would fail and lead to catastrophic failure of the hip joint arthroplasty.